All right, good evening, everyone. Welcome. I'm very excited to welcome you to this SSO and AAES Collaborative Multidisciplinary Management of Adrenocortical Cancer webinar. I'm Sarah Fisher. I'm an endocrine surgeon at MD Anderson. And joining me in moderating tonight are Dr. Lauren Krumeich from University of Michigan, as well as Dr. Mahsa Javid from University of Louisville. Of all of our extraordinary panelists, we have no disclosures. And I'm going to introduce our objectives tonight. Overall global view, to describe the standard of care in treating patients with adrenocortical carcinoma, to recognize candidates for mitotane and limitations or side effects to this medication, and to thoughtfully discuss the timing and sequence of multimodality therapy for patients with adrenocortical carcinoma. I'm excited. We've seen our moderator slide, and I'm excited to introduce our expert faculty. We have Dr. Carrie Cunningham from Mass General, an endocrine surgeon and a leader in the AAES. We have Dr. Thomas Giordano, a pathologist from the University of Michigan with a specific interest in adrenocortical cancer. Similarly, we have Dr. Mouhammed Habra, a medical endocrinologist from MD Anderson with a specific interest in adrenal neoplasms. And Dr. Matthew Nehs, an endocrine surgeon at Mass General. So as we go along, please be sure to put your questions in the Q&A box in the middle of your screen. These will be reviewed and answered as soon as we can. Any unanswered questions can be emailed to education@surgonc.org. We're going to start right off the bat with case number 1, and I'm going to turn it over to my colleague, Dr. Javid. Mahsa, take it away.
Thank you, Sarah. It's great to be here. Thank you for showing up, everybody. So our first case, we're going to be talking about a 50-year-old woman who presented to the ER with abdominal pain. In fact, this was a patient from MD Anderson, Sarah. And Dr. Mohammed Habra kindly informed us about this patient, which we thought might have some really pertinent points we want to discuss on this topic. So here's a CT scan. There was an ER scan that was done for abdominal pain, and you can see a big arrow pointing to a left adrenal lesion. So this patient didn't have any specific symptoms related to an adrenal lesion. She happened to have an incidental finding of a 2-centimeter left, what they call the suprarenal mass. Of course, workup was done. Somebody must have read the AAES guidelines that even any lesion in the adrenal over 1 centimeter should have at least some functional workup and at least a dexamethasone suppression test. So that was done, and it was normal, as were the plasma metanephrines and other hormonal workup. So this would be called a non-functional adrenal lesion. So in terms of the imaging here, the ER scan report reported this as having a pre-contrast density of 20 Hounsfield units and an absolute washout of 65%. I just want to turn this to our panel. Maybe, Mohammed, you can help us here. This is an ER scan. Would you be satisfied with having these numbers just on an ER scan, now that you know what a pre-contrast density is and what the absolute washout is? It's above our 60% absolute washout limit. So would this be sufficient for your management and making a decision as to whether or not to do any further workup here?
I mean, in the short term, yes. I think, this can be classified as maybe lipid poor adenoma, again, if you follow the radiology literature. And I think we have good confidence from the washout. However, I think the prediction for the future, should we depend more on the washout or the pre-contrast density? And this may be up for discussion, and maybe we need more data for that.
Great. So what if some, specialists are still going with perhaps some older guidelines? And I've often seen it, perhaps some of our other panelists have, where a radiologist might report a benign adenoma with a Hounsfield unit pre-contrast of about 15 or 18 Hounsfield units, rather than, let's say, the updated AAES guidelines that tell us it's okay to leave a benign lesion alone if it's over 10 Hounsfield units and has a greater absolute washout of over 60%. What would you do as someone who's in charge of managing these patients if you're told this is a benign adenoma with a Hounsfield units of 15?
I think, go ahead.
No. I didn't know who you were addressing that to. Go ahead, Mouhammed.
Go
No,
ahead,
no, no.
Mouhammed, and
Go
then we'll
ahead.
have Carrie next.
I think I don't love the scans they get in the ER. At least in our institution, they're not as the slices aren't as thin. I don't love the Hounsfield unit of 20, and it looks pretty homogeneous. The nodule does, so I don't think it's a matter of it's in a different in the wrong location where it was where the Hounsfield units were assessed. It looks relatively benign. I would also make sure that this patient was in the emergency room for some other reason. So these labs, they need to be drawn at a time remote from the emergency room visit. So I would probably repeat the scan or get an MRI.
Okay, anybody else have comments on this scan here? You've got a multiple choice. I think we would all classify it as probably a lipid poor adenoma. So let's just move forward and show you what actually happened. So according to the guidelines, the patient had a follow-up scan, which was at 12 months, and it turned out that this was a huge mass. Patient had surgery, turned out to be adrenocortical carcinoma, PT3, Y-score 8, Ki67 was 40%. I'm just going to turn the tables here and speak to our pathologist, Tom. This is why our colleague, Dr. Bill Young, is now telling us to remove lipid poor adenomas or any lesion in the adrenal that has indeterminate imaging, because he's seeing this more and more often. Is this a rare phenomenon to have a so-called lipid poor adenoma turn out to be an adrenocortical carcinoma?
You're muted.
Oh, yeah. Well, you're still muted, Tom.
If you're, yeah.
There we go. Can you hear me now?
Yes.
Yeah, so we've all seen cases like this. I think what struck me about this case was how quickly this developed. In my experience, it's many years before a tumor, maybe a patient's lost the follow-up and comes back for imaging and has such a large tumor. But this case leads me to make a few general comments, not sidestepping your question, but I think we have to remember that all cancers are really rather heterogeneous things. We refer to them as it, but it really is them. There's millions of cells in a tumor, and they're constantly evolving through growth and the accumulation of more mutations. So it's easy to envision a scenario in which this tumor, whether it was an adenoma, could evolve over time, accumulate more mutations, and grow into this clearly malignant carcinoma. And I see this all the time at the histological level, where I see tumors that have adenomatous areas, low-grade carcinoma areas, high-grade carcinoma areas. And we pathologists, we tend to focus on the big, fleshy, necrotic areas, and we often miss the fact when we're sampling these tumors that there's a little adenomatous compartment that's been pushed out of the way. But if you really sample these well, you can often find it. And the thought experiment for me is, what would this look like if it was resected 12 months ago? Would it just have been signed out as an adenoma next case? That's what I think. And I think this tumor evolved in a relatively quick time period into this obviously malignant carcinoma. Back to your original question, should all lipid poor adenomas be resected? I'm not sure I'm the best person to answer that question. I think this progression rate that I have in my mind is quite low. So we could be resecting an awful lot of adenomas with very little impact? I think that's a truly hard question to answer well.
I appreciate your thoughts. Perhaps this is one of the cases where we're given a bit of leeway to do a follow-up scan at 6 or 12 months. Perhaps lipid poor adenomas, we should do a follow-up scan at 6 months.
I mean, in tumor board, I play devil's advocate with my clinical colleagues because they say, well, let's get a scan in 3 months. And my argument is always, nothing is going to change in 3 months. It's too soon. Give it time. Tumor, but clearly in this case, maybe 3 months would have shown that this tumor really started to grow, because you can envision the intervals of this from 3 months, 6 months, 9 months. It really grew quite a bit in a year. Most adrenal cancers don't do this.
Yeah.
Okay, Matt, I know you're going to talk, but I'm going to push back right away. Is that the consequences of a missed?
No, I'm not worried with.
Let's start with Carrie, and then we'll go to Matt, and then Mouhammed.
I'm just saying, this is why, as I've gotten, 16, 17 years into my practice, I am much more, and these cases take an hour and a half. The patient goes home the same day. Anytime there's even a remote, once you have a 23-year-old patient who dies of adrenocortical carcinoma that was missed, I am much more on the Bill Young side, where because of this potential, right? It's the potential of a missed case. Sorry, Matt, go ahead.
No, my approach to this problem and all problems is exactly the same. It's Bayesian statistical reasoning. So the very first thing to think is, what is the differential diagnosis? And all adrenals fall into 4 categories. And it's a 2x2 matrix of benign or malignant, functional or non-functional. And 3 of those categories require an operation, generally. The one that doesn't is benign and non-functional. Except the problem is the probability of each of those is different. And the overwhelming probability is that the nodule that you're seeing is benign and non-functional. So it's an asymmetric distribution in that probability. So you have to reason through it. And you say, well, in this instance, this is a non-functional mass. So that category is already out. So there's only 2 categories left. That's it. It's a cancer, or it is a lipid poor adenoma. And so I agree with the group that you don't want to ignore this, because the probability isn't 0. No matter what the literature says, no matter what the radiologists say, absolute washout or all of these things, it doesn't exclude the possibility this is malignancy. I have only one case in my entire practice where we have 2 data points on someone who had a scan and then later was found to have adrenocortical carcinoma down the line. But it was like a 6-year interval of no follow-up. It was not 12 months. So there's something remarkable about this case that is exceptional and not the rule. So I think this case is illustrative because it demonstrates how important it is to have follow-up for something like this, but also the group should note that this is an exception and not the rule. One time I had a patient undergoing screening for Li-Fraumeni, P53 germline mutation, and they found a new 8 millimeter, not centimeter, millimeter nodule in the left adrenal gland. They asked me to remove it. I said, that's preposterous. They said, no, you should do it. And indeed, it was a small adrenocortical carcinoma. So do large adrenocortical carcinomas arise from adenomas, or do they arise from small adrenocortical carcinomas? I don't know. But my guess is maybe the opposite of Dr. Giordano's, that maybe there was a focus somewhere in this thing of adrenocortical carcinoma.
Yeah. We will not know for this case.
Well, if I could respond to Matt,
Sure.
Matt, I've been looking at adrenal tumors 35 years.
That's why I defer to you.
and I've been still looking for that case. So I still participate in the breast service. So I can diagnose a 1 millimeter invasive ductal carcinoma of the breast, but I've never seen. Now the Li-Fraumeni story is a little different, right? Because of the genetic predisposition. But in the absence of that, and we do learn a lot from genetic syndromes, but I've been looking for that small 0.5 centimeter adrenal cancer. And after 31 years at Michigan and before that, I've not found it. So I'm pretty established in my view that there's an adenoma carcinoma progression. In this case, if they had resected it at minus 12 months, that probably would have been signed out as almost certainly would have been signed out as an adenoma.
Wow.
That's my take. It's a hard thing to prove.
Yeah.
It is. And it's hard to prove the other way. We don't take out the less than 1 centimeter ones, as Matt suggested.
Yep.
So, but a quick couple of more minutes on this case. Obviously this is localized disease, and we need to think about how we approach it operatively and post-operatively. So let's say it was a bit more straightforward. You've got a 6.5 centimeter mass. It's functional. You're worried about the imaging characteristics. Who of you would obtain a PET scan prior to surgery here? No? Carrie says no. Matt?
So I get PET scans only to adjudicate, if it's photopenic, I might consider a laparoscopic approach because it lowers the probability it's a malignancy, and therefore a minimally invasive approach might be reasonable. Whereas if I feel like it's adrenocortical carcinoma, me personally, I'm going to do this case as an open resection, regardless of what the PET scan shows. So that's irrelevant information to me. But sometimes I use it only to modify the probability preoperatively of malignancy. If this thing makes androgens and cortisol, I think the diagnosis is done, and you do that open, me personally.
Is that what you would agree with, Carrie? Are you doing this open, or would you?
I am not. I am doing these robotically now. And I think it is I will say, having done them laparoscopically and open, that I would do open over laparoscopy, but I would not do open over robotic. I think that the robot is actually, I think, better than my real eyes. Obviously, if it's invading anything else, I would immediately open, but I think, especially on the right, I think that just to get to the dissection, and if you're very careful and you're very slow, and you don't need to remove anything else, I think the risk of perforating it is higher, making a huge incision and putting huge retractors in there and trying to get to it, in my opinion.
Great, thank you for that. Different experiences, and so we'll learn from all those. Just to finish up here, Mouhammed, when would you give this patient adjuvant therapy? You've got an R0 resection, let's say.
I need more information. I mean, besides the, again, Ki-67.
Ki-67, if it's about 20%.
I think we have, again, this will be based on, not based on data yet, but 20% at least I would have offered, I mean, maybe mitotein.
Mm-hmm. And if you've got an R0, you wouldn't be giving adjuvant radiation?
I mean, with R0, the data is not there for adjuvant radiation. Had the margins been R1, yes, I would. There's some support retrospectively from some papers for adjuvant radiation with R0. I mean, if it's good surgery, no report of fracturing the tumor. I mean, maybe mitotein alone.
Thank you. And I'll just finish off by showing you a horrific slide of what happens if we don't do an R0 resection at the index operation. This was, I guess, a failed laparoscopic resection with abdominal carcinomatosis recurrence. So thank you for promoting open and or robotic surgery for these cases. And I will pass it on to Lauren.
I will say, for the surgeons who there are cases that, like that woman that I still have her picture on my refrigerator. Her tumor was 20 centimeters and all necrotic, and it fell apart on the way out. And like that image in my mind, it doesn't matter what we did in taking that out. Sorry, that was just me. That was a little trauma response there, but obviously the safest approach is the best approach, but sometimes it's impossible, and these tumors are really, really aggressive. So Lauren and Sarah, what do you guys do? And Mahsa?
I'm open, Carrie.
All right. Your surgical, I figured the surgical oncology groups would be open. I mean, that's the teaching. I don't want to sell, bad. I think having experienced surgeons is the most important thing.
I
I think
also,
if it's not a very clear carcinoma, because there are these that are sort of
Oh, no.
suspicious, but you don't know. And, again, the likelihood, like Matt was saying, is pretty low. And I think in those cases, a PET scan might make me do an open resection from the start rather than trying to do a minimally invasive approach in the first place.
Okay. I'm going to learn from you guys too tonight. So this is good.
Well, and I think the overlying theme here is to avoid fracture, right? And to use your experience in the best approach possible to avoid that.
So
Lauren?
a lot.
I want to hear what Lauren does after
Yeah,
she.
Lauren.
my two mentors are panelists here. So, but I will say I do err on the side of open. I do also use PET scan to try to inform my approach. If I know it's an ACC or highly suspicious, I err on the side of open. But I have also started robotic adrenalectomy now about a year and a half ago, and I agree it is a new way. It's wonderful. I think the visibility is really exceptional in the articulation, and so I would feel safe doing a small ACC that way, but more so I'm using it for those indeterminate ones, because otherwise I think we would do a lot of open surgery for benign tumors. And I think that's where we run into the problem is what is our pretest probability? But I'm still working that out because I've certainly also had very PET avid tumors that I've approached open for that reason that have been benign. So it's a great thing to tell a patient after, but it's also, it would be nice to know that beforehand because you could optimize the approach.
Tom, do you want to tell us about the Weiss criteria?
Oh, so the Weiss criteria were developed by a pathologist, Larry Weiss, many years ago. The truth is, it's bread and butter pathology, right? It's tumor invasion, capsular invasion, vascular invasion, the presence of mitoses, necrosis. It's almost, I don't want to diminish what Larry did, because there was this mystique about adrenal tumors going back into the 60s and 70s that pathology wasn't useful on adrenal tumors. And Larry sort of said, this is rubbish. We can fix this. And he took a systematic approach to just bread and butter pathology features and showed that if you have, and if you add these up, not these 9 factors that you look for, if you get, more than 3, it's pretty much a carcinoma. But it's the field's almost too dependent on these scoring things. It's really just traditional pathology. But it's useful. It helps. So the hard part of adrenal tumors is that they're so rare. I get consultations where people say, I think this is adrenal cancer, but I haven't seen one in 5 years. And that paralyzes them. But if you're at a place that has a high volume, the pathology is not that hard. It really is traditional bread and butter pathology. But having said that, we see lots of indeterminate cases. We're doing IGF-2 to help sort those out sometimes. We do a lot of Ki-67 reticulin staining. So there are tools, but the classic high-grade ACC is diagnosed within a few seconds by a pathologist that sees these. And there's no Weiss criteria needed for some of these really high-grade tumors.
And none of them can be used intraoperatively.
Yeah, I mean,
Well, I'm telling you that we still don't know until the tumor's out. That's the problem.
yeah, I mean, you could do a frozen section, but it's not really going to, change anything that you do.
Yep.
Right. And we don't encourage, preoperative biopsies. I don't think anyone does, right? No.
Well, that discussion is pertinent here. So let's take this discussion to our next case. This is a case from the University of Michigan. It was a 74-year-old woman who presented knowing that she had a 9.5 centimeter left adrenal mass. She had had flank pain for about a year and had also noticed really profound changes in her body, including hirsutism and facial fullness, central adiposity. She had had an open cholecystectomy via right subcostal and some LAD stents, but was otherwise relatively healthy. And her exam was consistent with what she had noted. She had dark hair throughout her body and the central adiposity as noted. So one thing that I wanted to stop and pause right here, you'll also see she has some hypertension. With what you know even from here, how are you counseling this patient? Like, what's your pretest probability that this is an ACC from what you know already?
It's 99%, Lauren. So you can make the diagnosis of ACC in the grocery store, and you should. If you see a woman with hirsutism and Cushing syndrome with a round face and a buffalo hump. She has adrenocortical carcinoma and needs to get to an endocrinologist stat. So that is not PCOS. And I have this woman. I cared for her. She literally was the daughter of a pituitary neurosurgeon.
Oh, come on.
Literally, who did not make the diagnosis. I saw her. She's 34 years old. She had facial hair, like a beard, like me. Okay, and the treatment that she was prescribed was laser treatment for the hair. Okay, she had a round face. She had a buffalo hump. She had all of these things. There's only one thing that does that, and it's adrenocortical carcinoma that makes androgens and hypercortisolism. That's it. Because PCOS is not that. Obesity is not that. They're related, but not all of that at once. So this patient, not just because this is the adrenocortical carcinoma webinar, has this, but because everyone who has these two things has this. And I know that's a rare incidence, but a young woman with facial hair and a round face has adrenocortical carcinoma until you prove otherwise.
And interestingly, when she came to us, she did not think that she had adrenal cancer. This was not something that had been discussed with her.
There is no doctor who thinks this, or they should, but they don't.
But this is what we discussed with her, is that, without any additional information, we felt similarly that this was the diagnosis until proven otherwise. So we were certainly on board with it. And I think it's really important to counsel patients because it's an aggressive cancer and we need to be aggressive about our approach. And that's, sort of how we frame it. So thanks for that input.
I will just echo that. If there are two lines of hormones that are abnormal, that is a very high pretest probability. That is well, obviously it's 9.5 centimeters. So that's but even just the two, just like Matt said. So if there's two different lines of elevated, that is a huge red flag, and DHEA as well.
Yeah, and I'll show you the labs in a moment, but just to bridge off of what Tom was saying. So this patient did come to us having had a biopsy. We agree we don't normally recommend them except in rare cases. Typically, if you aren't going to operate and it might guide your other therapy. Are there any other instances where you do find it helpful? And I also wanted to ask, have you ever seen this theoretical risk of seeding the tract? Certainly the biopsies aren't typically helpful. You'll see this one is just adrenocortical neoplasm of uncertain potential, so it's not that informative. But yeah, have you seen the seeding? Have you ever found this to be helpful or harmful?
Matt?
The short answer is that all tests, no matter what they are, only do one thing, that's modify the probability of what you knew previously. So there's some case, and they're important to get if they modify what you do. So for example, in the case of this kind of thing, there's no reason to biopsy it because you know the diagnosis right up front. There is no sarcoma that makes cortisol and androgens. That doesn't exist. There's not a ganglion neuroma. There's not other things that do it. So the diagnosis is made already just from your kind of modification of pretest probability and the hormones that it's made. There are some cases where the biochemical workup is totally, totally flat and negative. And biopsy actually is quite useful in those cases because sometimes it can avoid altogether an operation. If it comes back as likely ganglioneuroma, don't operate on that or steer clear of it. And that will save the patient a large operation. So yeah, biopsy is perfectly fine. And I don't know that this concern about seeding the tract is as worrisome as we think it might be.
So for me, the times that I biopsy, Lauren, are secondary malignancies of the adrenal gland with rare instances. First of all, everyone needs to remember that I don't know if this patient had her plasma metanephrines drawn, even with all those other things done. I recently saw a patient, actually a thoracic surgeon at an outside hospital, sent a patient with an adrenal tumor for biopsy before checking a plasma metanephrine, and the patient coded in the radiology suite. So it still happens. So obviously make sure that doesn't happen. But what Matt mentioned, and I've seen more and more of these recently, is these, and what Tom said, there are a million different cells, right? I had a leiomyosarcoma that was invading the IVC. there have been lots of ganglioneromas and these other sarcomas. So those I find helpful to biopsy if there's some debate about whether or not, if that's on the table.
Great, thank you for the discussion. So consistent with what we've been discussing, she did have elevation in two different lines here, cortisol and androgen. And I want to point out her 1 milligram dexamethasone suppression test was quite high at 21. And I think this does become relevant as we start to talk about the surgical approach, which is also a question that we have in our Q&A right now, is thinking about extent of resection, lymph node dissection, et cetera. So I'd like to pull that discussion in as we move forward. I'm going to show you some slides now, just some cuts to avoid the terror of trying to put a video on here. So this was the tumor here. You can see the Hounsfield units on the non-con are about 40, and the washout is less than 20%, so certainly consistent with an ACC. We did do staging, and the chest was negative. And I'd like to just show you a few cuts of some things that we were thinking about in terms of our preoperative planning, and getting your thoughts on how you counsel patients about this when you're thinking about extent of resection, how aggressive to be about a case like this. We thought about, do we have a margin with the pancreas? I want to point out also her GFR was suppressed to 55 pre-op, and she had no risk factors for kidney disease. And so we were questioning that left renal vein there, if there was some compression. It did seem like we had a margin on the kidney, but just yet, any other thoughts from the surgeons as you counsel the patient preoperatively about a case like this?
I think I just was discussing a case like this in an M&M this morning, and this is actually wound up being a myelolipoma, but it had basically encased the renal vein. And I hadn't had that pre-op conversation about taking someone's kidney I think it's really important in this case, because even between the scan and when you take her to the operating room, if it's an adrenocortical carcinoma, it could get to the point where you need to resect the kidney. And the one thing I would check, which is what you did, is to check her GFR and make sure her the function of the kidney. You can also do what they did in the transplant, right? The functional scans for the kidneys. I think that's helpful as well. I don't know if Matt, you've anything else.
Yeah, I'm a big fan of left upper quadrantectomy when necessary. It's not always necessary, and in fact, it's usually not necessary. But I also kind of play the another 2x2 matrix. It's something like this. If you do the correct operation for cancer or not, and if it's malignant or not knowing either of those. So that's, again, another 2x2. So if you do the correct oncologic operation, in this instance, you get an en bloc resection of maybe the distal panc, spleen, nodes, perinephric fat, kidney, just the whole left upper quadrant is out of there. And it is a cancer, you've done the correct thing, and it all works out well. If it's benign, it's out of there. It's great to not have resected all of those things, but on the other hand, the patient will still be okay. However, if you shell out a high-grade aggressive adrenocortical carcinoma, leave it behind, leave a margin on the renal vein, or more specifically, the renal artery, medially, that's very inflamed. So the renal artery is often the thing that's encased in the rate-limiting step on whether you need to do a nephrectomy or not. ACCs almost never invade the parenchyma of the kidney. They're adherent to it, I know, but they actually invade the vasculature, or they surround the vasculature such that you can't really preserve the renal artery. And so you're going to infarct it. And so instead of worrying about that, you just resect the whole thing. So it really depends a lot on, do I think I can take out this ACC? Because this is your one shot to cure this problem.
Thanks for those comments. So we did speak with her about, the possibility of the left nephrectomy. We didn't know why the GFR was low in her. If it was not due to that compression on the left vein, then we did discuss that, there's an increased probability of needing dialysis, at least in the short term, if she were to have a kidney removed, given that she was coming in with suppressed renal function. And she also had an increase in her A1C, which I think was related to the cortisol, because then it hadn't had any diabetes throughout her life. So we also talked about, depending on if we needed to remove any pancreas, that she could have an increased risk of requiring insulin. So these were some of our preoperative counseling discussion. So consistent with what we've been speaking about today, we did perform an open left adrenalectomy. We were prepared to take out and do a left upper quadrantectomy, as Dr. Nehs had described. But we were able to actually remove this without any involved organs. It really came right out, which was consistent with the low-grade oncocytic pathology that we'll see momentarily. The course was, I think, mostly complicated just by how high her cortisol was preoperatively. And I'd like to take a moment to remind our attendees that that can be really challenging due to the patient's tissues. Some of the things we encountered was she had a lot of retroperitoneal ooze. The tissue quality was very poor. And postoperatively, she ended up having a GI bleed, even though we didn't do any GI resection. She was in and out of the ICU for various reasons and needed multiple rounds of stress dose steroids, which I think probably precipitated some of her GI bleed issues. And probably one of the most challenging aspects of this case was she was really altered mentally in terms of probably from the high cortisol, just feeling really depressed and perseverating quite a bit because she had lived with this for so long, and her husband just kept saying, like, this isn't my wife. And so that made it really a challenge to get her buy-in for some of the things that she needed to go through. But overall, she did very well. She recovered beautifully after these few bumps in her post-op course, and her renal function actually normalized immediately after surgery. So we thought maybe it was that compressive issue. But just looking to the panelists, especially the surgeons, any other post-operative issues you've seen with a cortisol that high, or issues in the OR bringing people back together?
For sure. So the highest cortisol levels I've seen are people with ACTH-dependent hypercortisolism. Specifically, I had a man who had a pheochromocytoma that made ACTH, that gave him hypercortisolism. If you pee in a jug for a day, you should get 30. He had 10,000. So a cortisol of 10,000 for 24 hours. He was frankly psychotic, and I had to consent his wife because he was unconsentable. It took him months and months to recover from this, just from a neuropsychiatric perspective. So yeah, the neuropsychiatric effects of hypercortisolism are absolutely real, and also the tissue effects too. Cortisol is a stress hormone, is meant to deal with acute stress today, right now. It's not meant for long term. It chronically rips your body apart, and it turns all of your tissues, your protein, your collagen, everything into mush. So all of your tissue is weak, and everything's going to bleed, everything's going to ooze. All of the things you've described is exactly what you expect for the highest hypercortisolism cases.
Yeah. We also counseled her a lot on incisional issues, should she have a hernia, things like that post-operatively as well. Carrie, I think I saw you starting to make a
No, I
comment.
just thought maybe you're probably going to cover this, but Mouhammed, maybe he could comment on how much steroid in the operating room for stress dose, or how to do that, maybe the morning, cortisol test. Tell us what your thoughts are on that, because I'm still learning how to do that.
I mean,
Well,
I don't think there's a uniformly accepted way. Each one has his or her own way approach it. I mean, the way I approach it, actually, knowing this is localized disease, they will become adrenal insufficient as soon as you remove this tumor. So I always communicate with anesthesia, to give them, some IV hydrocortisone, possibly 100 milligrams at the time of anesthesia induction. Then maybe another dose can be repeated, possibly 4 hours, more than the 6 hours, maybe 50 even. Maybe 50 Q6 in the first day, then taper it down slowly, depending on how the patient is doing. But definitely they will need to go home on steroid replacement, maybe higher than the average replacement in the first week or so because of the stress of surgery.
And we also counsel on a prolonged mean for these really high cases as well. I want to be mindful of time here, but I will be getting in Tom and Mouhammed now for the last few slides as we think about her pathology, whether or not to give adjuvant, and what her post-operative course has been like now. So this was the pathology, I believe, read by Tom originally. Is that right?
Yeah, I think I remember this case. Yeah. So,
yeah, please. Do you want to comment?
So, a couple of things. Oncocytic subtype. When we think of oncocytic, we generally think of the thyroid, because oncocytic is the preferred term of Hürthle cell tumors. But it's the same thing. It's a cell, it's an endocrine cell that accumulates a lot of mitochondria and other organelles that give it a very granular appearance and a very eosinophilic appearance. Now, adrenal cells are pink cells to begin with. So you get into this definitional conundrum of like, how much of that granular cytoplasm do you really need to be oncocytic? But that's getting down in the pathology weeds. But I mentioned the mystique of the 60s and 70s. I must admit, if I'm being honest, there's still a little mystique when it comes to oncocytic adrenal tumors. And I would say that they're the hardest to evaluate for a couple of reasons. One, we count mitoses, and oncocytic tumors tend to have these funny looking nuclei that look like mitotic figures. And the way to sort that out is the Ki67 and the mitotic index generally are pretty tightly correlated. So if I get a case from another pathologist and they've said, oh, the mitose, it's a high grade tumor, but the Ki67 is only 7%, there's a problem there. And I see that all the time. One way to sort that out is we actually have a special immunostain just for mitotically active cells, and you can do that to sort of talk someone down from a high-grade tumor. But these are hard to do, and we do a lot of work on them to try to get the diagnosis right. So you could see we did a Ki67, we probably did a reticulin also. We do IGF-2 when we need to, and so we look at all these factors that you can see here that go into, the Weiss score and other systematic scoring things. We don't use Weiss for oncocytic tumors because one of the criteria for Weiss is whether the cells are very pink. So under the Weiss criteria, they get free points. So there's other criteria, and I won't bore everyone, but you should not use the Weiss criteria per se for an oncocytic tumor. So, but this is a low-grade tumor with a Ki67 of 10 to 15%, and less than 20 mitoses. And if you look back to that imaging, it sort of had a smooth border. It was very not very infiltrated, but we did find some capsular invasion, but no necrosis. And there's a strong correlation between the biology of a tumor and how it behaves. It was just with the presence of tumor necrosis. So I would think that this tumor would, even though it's PT3, has a pretty good prognosis.
So in the interest of time, I will say that this was discussed at our tumor board, and we did not feel that adjuvant therapy was warranted, and we'll discuss whether or not that was the right decision if anyone else has any other thoughts. Within 8 months, she was found to have some scattered sub-centimeter hepatic lesions, nothing locally. So what would you all recommend at this time? Maybe bring this to Mouhammed.
Yeah, I mean, this is one of these cases because, again, I think you are treating now, I mean, oncocytic adrenocortical carcinoma similar to the regular, because, again, these cases are rare enough. So, and I think at the end of the day, we may just separating them like we did with thyroid cancer. So until then, actually, I mean, yes, I mean, these cases with the Ki67, 10, 15%, yeah, I mean, there is risk of recurrence. I would have expected local recurrence more than distant, at least on the first scan, with the positive margins. But again, this can happen. So, but still, I'm tempted to confirm this pathologically before I go for definitive therapy. Most likely, these are metastases, but I want to see how different are they, at least with the molecular testing from the original tumor.
Yeah, I think that's a great point. And in the interest of time here, I'll say that she got SBRT for a few fractions, and then you'll see quickly developed new liver tumors, and really just in a matter of months has had really profound liver involvement and has been undergoing Y90. So another, oh, please.
Good, Lauren, I just want to chime in. I want to make one point. Just because the tumor starts out low grade at the primary doesn't mean the metastases are low grade. Back to one of my original points, tumors evolve by growth and mutation. So I still grade metastases when they're biopsied or resected because it gives the clinical team some input. So I would argue this is evolving into high-grade disease with this degree of liver metastases.
But also, I mean, the timing of these metastases, I mean, when I see these relatively early metastases, I mean, what we're seeing on the initial MRI was the tip of the iceberg. So I think this is indication for systemic therapy at that case, because, I mean, this is what we typically see. Had I seen this 2, 3 years after, yeah, I think there's higher chance for controlling the disease with localized therapy.
Mm. Thank you. All right. Well, in the interest of time, let's proceed to our last case. Thank you all for your comments.
Okay.
Sorry,
Well,
I can't help myself. I have to make one comment. I have seen cases where the Mets start, even if it's widely metastatic, but the Mets are secreting the hormone, and it can be very difficult for their quality of life. So I've had our radiation oncologists target like larger lesions to try to get that burden of the hormone down a little bit. Just something to consider for palliation more so than anything else.
and that brings up an excellent point, Carrie. And one of the cases we were considering putting on was a palliative debulking for help with control of hormonal excess. But that is not this case. And by now you guys all know that we're talking about ACC, so I'm going to go quickly through the history. This is a 25-year-old female, Matt, with facial swelling, amenorrhea, lower extremity swelling, and we'll throw in some facial hair in there too. Presented with significant hypertension, moon facies on exam, facial hair growth, palpable mass in the left abdomen, pitting 2+ bilateral lower extremity edema. And sure enough, on biochemical workup, she has both DHEAS as well as cortisol excess. So we have our diagnosis. We've discussed that. We've clarified that. This is her initial presenting scan. And you see I put lots of little arrows in there, but you can see that from across the room. She has a huge left upper quadrant mass that extends into the left renal vein and tracks up into the cava, up into the level of the atrium. And I will also draw your attention to over here where there are liver metastases. So what do we do now? Dr. Cunningham, Dr. Nehs, any role for surgery right
Hoping
now?
that Tom was going to tell us what this phenotype is of the 23-year-olds with horrible adrenocortical carcinoma that you've discovered what the mutation is.
Well, I mean, the Cancer Genome Atlas described these mutations. It's nothing out of the ordinary. It's P53 and RB, a lot of tumor suppressor loss, IGF-2 dysregulation.
I just mean there seems to be a bimodal
Oh,
distribution.
like why is this so bad?
Yeah.
Yeah. I'm not sure I have a great answer, Carrie, to be honest. We're still learning about these, but this is not. I haven't seen a case like this in a long time, but Norm Thompson used to love to operate on these patients. He would put them on assist and take the whole thing out, go all the way up to the heart. We don't really do that anymore.
Well,
We
Ahmed.
do. We do.
You still do?
We sure do. And I'll tell you why. There's two reasons. The first is the first thing I do about this kind of patient that diagnosis is made is I really assess what is it they hope to achieve. That conversation sets the premise for absolutely everything that occurs from there. And a 25-year-old young woman, a lot of times they come in and they say, I just want to live a normal life, or I want to live as long as I can, knowing that they're probably not going to be cured of this. It's very hard to cure this systemic disease. And then once we set our goals, then we talk about a little bit of what are we willing to do to get there? And what is the purpose of surgery? So the debulking of adrenocortical carcinoma is a incredibly contentious issue because the outcomes are already poor. There are some places that say it doesn't make any difference, everyone dies, and other people disagree with that. My contention is that if there is any hope, it does lie in radical debulking for this. The reason relates to the hypercortisolism. So hypercortisolism impairs your immune system, and your immune system is a way in which your body fights cancer, or at least could potentially fight it. So if you can debulk the disease, including IVC thrombectomy, etc., big radical surgery, knowing there's going to be micrometastases in the liver, the chemotherapy, either whether it's EDP or it's immunotherapy or whatever, has a better chance of being functional in some way to mitigate the effects of hypercortisolism. And even if it doesn't work still, a lot of these patients do benefit from the debulking effects because the hypercortisolism isn't so severe, and therefore the rest of their life is more palliative. So this discussion occurs in both domains. First is, it's possible that you'll live longer because we'll debulk the cancer, it'll progress slower, will mitigate the effects of hypercortisolism, which may improve your response to adjuvant therapy. That isn't known. There is not and never will be a randomized trial to show that because it's too rare of a disease. But it's plausible, biologically plausible. Second, and I learned this from Anand Vaidya, who is our adrenal endocrinologist. And Anand said, he says, when you don't operate on them, they die of fungemia. They die of severe immunosuppression. They die of pneumocystis jirovecii. They die of things that are like HIV because their immune system is nothing and they get all these opportunistic infections. Surgeons, we never see that stuff because that's not the consult we get. But a lot of other doctors are dealing with these severe things as consequence of hypercortisolism. So sometimes we'll offer this to a young patient, well-selected, caveat, when it's consistent with their values, interests, and beliefs.
So Matt, if I could just counter that, because
Please.
I've worked with a lot of endocrine surgeons, I appreciate your argument, but I also know someone who used to be at Michigan who would make the following argument. He goes, I would operate on you, and while you're recovering, the rest of your cancer is going to blossom, and it's really going to be counterproductive. So I do think it's a little controversial, but I agree about the cortisol and the
Yeah, I definitely don't. I don't want my comments to seem as if there's a wealth of evidence behind them because there isn't, and there never will be. And so you're hearing one person's opinion from a biologically plausible mechanism. My view is that ACC is aggressive not because of some mysterious biology of the disease, but in part because it makes cortisol. Many tumors are smart enough not to make cortisol because they can't. They get to it through a secondary means, that's ACTH. And they do that because they want cortisol, because they want immunosuppression, because the immune system suppresses the cancer. And so if you can get to that, it's sort of teleologically beneficial for aggressive cancers to do that, to suppress your immune system in some way. So if, as surgeons, we can mitigate that in some way, there may be a benefit to that. And again, would you do that in a 80-year-old? I don't know that you would. What in a 25-year-old who says, I will do anything to not die of this and not die of this in a horrible way? I think if you can partner with your vascular surgeon, your cardiac surgeon, all of the above, every doctor you can marshal to do this, I think it's sometimes in select cases a reasonable thing to do.
And so there's role in palliative debulking and controlling the cortisolism. But Mouhammed, what other options do we have to control the hypercortisolism?
So, I mean, there are multiple options. I mean, these days, I mean, it's pretty much the same options we had before, like meterapone. Again, it's not FDA approved here, but it is approved in Europe. But we used it for years. I mean, osilodrostat, I mean, again, it's another enzyme blocker which works super nicely too. Mitotin itself, you can view it as a dual agent, enzyme blocker plus down the road, this will be, that will have some cytoreductive, I mean, issue. But the main thing here is achieving quick cytoreduction. Because I don't think just hormonal manipulation will be enough to control a huge tumor like this. So whether it's chemotherapy or surgery, I mean, we need to reduce the number of these cells, I mean, as soon as possible. This is my take on it. I mean, just 2 cents on this. Again, I'm not a surgeon, of course, but I mean, my negotiation part will be, will the patient miss a kidney during surgery or not? Because knowing that this patient will need at least adjuvant therapy down the road, which will likely adjuvant chemotherapy. If the kidney is going to be preserved, yes, I might be more open to upfront surgery. When the kidney is going to be removed, we will lose the opportunity for cisplatin in most cases. I favor maybe new adjuvant therapy upfront.
I'm on the neoadjuvant side. See if it has
And-
any response.
And as you know, Mouhammed and I are both at an institution that heavily favors that as well. So this patient had a biopsy because it was going to change what we did. confirmed the diagnosis. Had a low Ki-67, we got to remember some sampling error in there.
Yes, lots of sampling error.
And for the sake of time, I'll tell you what we did. She was started on medication, ketoconazole, mitotane, spironolactone, blood pressure medicines, and she was started on EDP. She was reviewed at Multidisciplinary Tumor Board with a consensus to treat to maximal response prior to considering surgical intervention. And I'm going to show you her presentation slide, her presentation imaging on the screen left, as well as 10 months later. You can see a small amount of tumor thrombus in the cava. The primary, which I'm going to show you on the next slide, has had significant response. You can see rounding of the borders. You can still see tumor thrombus tracking into the left renal vein and then up into the cava, but significantly less burden than what she had. Her hormone excess symptoms have completely resolved. She's lost her hair. She has some peripheral neuropathy, but she's still in good performance status, probably a 0 to 1. And the coronal views are probably, the most telling. You can see the primary tumor. You can see the trace of the thrombus tracking up. I couldn't get the whole image to capture on one slide, but clearly a very dramatic response here. So now what? Carrie, Matt?
Yeah, now you got to take it out. You got to give it a shot. And that you can pull, sometimes you can just pull that stuff right out of the vein. That's kind of fun to do, but this is incredible. It's nice to see. Was she on the EDP for like nonstop, or how was that given? I mean, that can be toxic for 10 months, right?
Yeah, I think we have a 25-year-old biology here.
Yeah.
She tolerated 8 cycles really relatively well.
Quick question from Sarah Altman. Did you biopsy the primary tumor or the liver met?
Believe it's the primary. Yeah, but also a good point. Obviously, you could get the tissue diagnosis from the liver and avoid the concept of
what Tom just said.
Tom?
I'm sorry?
Biopsying, the importance of biopsying a metastasis as well as the primary.
Yeah, I mean, I think
Right.
whatever's easier and better for the patient, as long as you get a good sample, I think you can make the diagnosis from either with ease.
So this was a patient that was treated before my time. I want to thank my colleagues, Dr. Jeffrey Lee and Dr. Tom Maloya, for taking care of this patient in conjunction with Dr. Habra. And they took her to the OR and took out her adrenal, her left kidney, did a retroperitoneal lymph node dissection, did do a venotomy and primary repair of the cava, like you said, Carrie, just milking it out. 2 of her liver lesions were identifiable in the OR and were treated with ablation. And a third was treated with a small partial left hepatectomy. And it is my great pleasure to tell you that she is alive and well more than 10 years after that. Tom, I'm gonna put you on the spot. Here's her pathology.
Yeah, so these rare atypical cells, this is what pathologists call chemotherapy effect. And then we debate whether these are actually, they're still stained with hematoxin and eosin, but they might be terminally damaged. We have a case like this at Michigan where I scoured the whole thing and found like a 1 to 2 millimeter area of adrenal cancer that looked unperturbed by the chemo. Everything else had this chemotherapy effect with these rare atypical cells, and so this is evidence. We see this in breast cancer. We see this in all kinds of cancers that have been treated with chemotherapy. The damage to the cells makes them have these rare atypical cells. So it's a recognized phenomenon, but whether they're actually going to recover and become a recurrence, no one really has that figured out. The H&E morphology is not good enough to decide that.
And, we have great data in the melanoma world that hyalinization in particular is associated with better prognosis and less chance of recurrence down the road. And I don't think we have the numbers and the volume to see that in adrenal. But I was curious if any of the panelists had encountered such a path response and what it translated for them.
I wish.
Yeah, never saw this for ACC. I took out a huge left adrenal met from a patient with esophageal carcinoma, and it was fibrotic, stuck. It was 10 centimeters easily, nephrectomy en bloc, the whole thing. And it was a kind of one of these radical approaches with the thoracic team who was really pushing for this. And this was supposedly the only focus of disease, big open surgery, etc. And every cell in that thing was dead. It was a treatment
Yeah.
effect, and we were astounded. I was a little bit upset about it because I took out the man's kidney. It's a huge operation. I was personally scarred by it. It was
But
very,
if it was the other way, you would have said, "Oh, it took out too little." You never. It's a
I
little.
100% agree. You always want everything just perfect as a surgeon, to not too much, not too little, etc. And it's wrong in every way. But we sort of celebrated that it was all dead, but it's a reminder that sometimes the chemotherapeutic effects do result in this fibrotic hyalinization, et cetera, et cetera. I just never even heard of it for ACC. This is a fantastic case. It's like every day of my life I learned something new. I never even heard that this could happen for ACC.
Yeah, I've got one in my collection.
That's great.
Well, as you pointed out in the first case, perhaps an exceptional but very illustrative case, I think we chose these on purpose because I think it highlighted our discussion. We all recognize that this is not the norm, but it's certainly nice to end on a positive note.
And I think you're highlighting, and maybe any of those from Michigan, how the importance of working collaboratively across institutions. And I don't know if you guys want to talk about A5 and what we're doing tonight, the SSO and the AAES, both people who treat these patients, having these conversations. I've learned a lot tonight. I'm like wrapping up for you. I didn't mean to do that, but maybe you guys just mention, I had reminded myself about A5 and Gary Hammer and Tom and everyone who's at Michigan working on this collaborative group, but maybe some people in the audience don't know and want to start some research projects. And so maybe you guys could chat about that.
And you're setting up Mouhammed very nicely.
Yeah.
Mouhammed, take it away with A5.
I mean, everyone is welcome now. So, I mean, we have now the new website for A5, and more changes are coming to A5 even to make it more open and easier to collaborate between centers. So this is perfect timing for this. Again, thanks for bringing this up also.
Yeah, I mean, the only way we're going to make progress in this field is to work together. I happen to be the co-chair of the TCJ Adrenal Project, and at first they didn't want to do it because they said you'll never find enough tumors. And I recruited Gary to help, and we said, we have friends all around the world, and we persisted and got it done. It was a smaller project, but that would have never been anywhere close to being done if it was a single institutional study.
And we will absolutely put the website in the chat for A5. And
Sarah, do you have the new website address? Maybe I can even share it with you circulate.
that would, yes, please.
Let me see if I can find. I'll put it.
And so,
Okay.
Lauren, or I'm sorry, Mahsa.
I think Lauren had a question. Did you want to bring a question just since we have about 1 minute left, even though we're overrunning?
Mine is 1 minute left. Well, I was just trying to touch on that very first Q&A because I thought maybe it would be relevant to Sarah's last case where thinking about extended resection, because you mentioned your lymphadenectomy and wanted to touch on for the surgeons kind of what your ideal extent of resection is when you're doing these. I mean, I think we talked about being aggressive, getting a negative margin, not rupturing the tumor, but as far as extent of resection, if you had any other pearls before we do our final wrap up.
I don't know what this exact compartment is for the retroperitoneal lymph nodes, Matt. Maybe you can give me. It's not like doing a lateral neck dissection. It's like you take out everything that's when you're in there. The ACCs, nothing looks like it's supposed to look, right? So I just try to take out as much tissue as to get to a normal margin, and that includes completely clearing off all of the diaphragm and posterior to the psoas and everything else. But I don't know, Matt, if you have any comments about lymph nodes or.
Yeah, my approach to it is pretty simple. It's there's two best friends in adrenocortical carcinoma surgery. First is the diaphragm. It is your favorite best friend. The second is the kidney. Both of these things will guide you and help you. And the sort of objective and goal is to take out everything that isn't those things. So I skeletonize the kidney and I shell the kidney out of everything else unless I'm taking it out. And I go down to the diaphragmatic surface, the quadratus, the psoas, etc. There can be nodes in between the cava and aorta that are positive, or on the left, things that are on the left lateral aspect of the aorta. And you have to really study the scan case by case. Sometimes there was one of the path slides showed a ganglioneuroma as a nodule. There are ganglioneuromas and little things along the length of the aortic chain that seem as if they are going to be Mets, but they end up not being. So I've taken out a whole bunch of these kinds of things, and
Me too.
in the end, it doesn't end up being anything in addition, and there is no metastases. Most adrenocortical carcinomas, in my experience, I guess, which everyone's experience is limited because it's a rare disease, but they're pushers. They push everything aside. They're not really locally invaders specifically into the aorta or into the kidney, but they push it aside. And when they invade the vessels. Tom can comment on this. They invade the blood vessels, the lymphatics, and they're going to spread hematogenously through the renal vein, the adrenal vein, etc., into the lungs and the liver, etc. So can they go to the lymph nodes? Of course, absolutely. And I look for them when I'm there, but I would say it's probably less common than the hematogenous liver lung. Tom, do you agree with that?
Yeah, I do. We clearly see positive nodes, but it's not that common. We do see occasional tumors that grow right into the liver parenchyma, so it does happen. And the pancreas too is susceptible. But like your comment about the kidney is definitely true. They grow onto the surface of the kidney. They can over time, if they have enough time, get into the kidney parenchyma. But yeah, I agree with your comments. Generally, they do like to get into those lymphatics and blood vessels, and off they are.
Well, thank you so much. This has been an absolutely wonderful and fruitful discussion. And I think you're all right when you say, we learn and get more out of all this when we're together. So it's been a wonderful multidisciplinary team. Such a wonderful discussion. Thank you to our expert panelists. I'm certainly going to have to watch this again to glean all the insights you've shared with us tonight. So thank you so much.
This is great. Thanks for having us.
Thanks.
Bye, everyone.
And just before people go, we do have a few announcements. Mahsa, do you want to go through, or you want me to?
Please, if you are not already an SSO member, please consider joining. There are lots of benefits, such as networking with all these colleagues, but also you get some discounts on the SSO journals and continuing education. The Surgical Oncology Insight is the new SSO journal, and it's open for people to submit their papers. Please go ahead and do that. If you're not already aware, SurgeOnc Academy is the new hub, and please be aware it will be member-only access beginning in 2026. There are some conferences coming up, so get those abstracts coming in. Advanced Cancer Therapies. In February, I think the deadline for submission for that is October 20th, and then the SSO annual meeting itself in March, and the deadline for abstract submission is October 13th. And if you're a fellow, the Fellows Institute is coming up and registrations will be open shortly. And finally, of course, our collaborators, the AAES meeting, come to Kentucky for the meeting in April. Thanks, everyone.
Great to see everyone.
All right. Thank you all.
Thanks. Good to see everyone.
Good night.